it's cystitis, then it is male or female. If female, and then how old? Okay. So let's assume this is cystitis in a young adult female with no comorbid conditions. Then what will be the drug of choice as per this culture sensitivity report? Okay. Always, as I already said, always start with the beta-lactam if possible. Here, beta-lactams are sensitive. In uncomplicated UTIs with ESBL organisms, we should go ahead. We can go ahead with normal oral formulations like nitrofurantoin also. Okay.
No.
Microbiologist always has more information. If you are getting ESBL E. coli and you want to add some oral formulation, there is one option of phosphomycin sachet also. For that, you can ask microbiologist to check the sensitivity, and single sachet of phosphomycin can be given to that patient. What are the preferred? Now there are a few questions before completing my presentation. What are the preferred antibiotics for the treatment of uncomplicated cystitis caused by ESBL enterobacterials? The same which I asked. Nitrofurantoin and trimethoprim sulfamethoxazole combination are preferred treatment options for uncomplicated cystitis which are caused by ESBL enterobacterials. These questionnaires are taken from IDSA guidelines which are revised final in 2022. So these are most recent. What are preferred antibiotics for the treatment of pyelonephritis and complicated UTIs caused by ESBL enterobacterials? Here we will go ahead with PNMs, but we have when we receive the patient and empirically we are suspecting it can be UTI, and we have already started piperacillin tazobactam with that. Then will you stop after getting this report, or what will you do? If patient is clinically improving, even with piperacillin tazobactam, then we should continue with that, and after that we can switch to some oral formulation. And if patient is not getting better, then we will go ahead with ertapenem, meropenem, or any imicilasten, ciprofloxacin, our antibiotics. Okay? What are the preferred antibiotics for the treatment of infections outside of the urinary tract caused by ESBL enterobacterus? The recommendation is carbapenem is always preferred for the treatment of infection outside UTI which is caused by ESBL organisms. After appropriate clinical response is achieved, then transition to oral fluoroquinolones or trimethoprim sulfamethoxazole should be considered if susceptibility of them is also demonstrated. These were questions about ESBL. Now one is carbapenem resistant enterobacterus. What is CR? What are CRE? How do you define CRE? Any organism who is resistant to at least one carbapenem antibiotic, that is called or our carbapenem is producers. They are called carbapenem resistant enterobacterus. Okay. For that also same question in culture sensitivity repair. How do you determine it? We will look at the ertapenem MIC values. If ertapenem MIC values are more than 2 mics, then it is considered as carbapenem resistant enterobacterus. Pseudomonas has intrinsic resistance to there are three organisms, 3 bacteria who have intrinsic resistance to imipenem. Those should be avoided. Those should be excluded from this criteria. Those are Proteus, Providentia, and Morganella. They are intrinsically resistant to imipenem. So when we are getting these organisms in the culture report, then we have to look at the resistance pattern to other carbapenem. If other than imipenem they are resistant to even one carbapenem, then they are considered as CRE. So what is preferred antibiotic for the treatment of infection caused by CRE, uncomplicated cystitis if it is caused by CRE? What will you prefer? Recommendations are ciprofloxacin, levofloxacin, trimethoprim sulfamethoxazole, or nitrofurantoin can also be given, or a single dose of aminoglycoside can be used in this. When we talk about oral phosphomycin, in these cases it can be used, but that should be limited to if we are suspecting in E. coli only, because Klebsiella, Pseudomonas, these organisms have intrinsic phosphate gene which hydrolyzes phosphomycin. In those cases, phosphomycin doesn't work. What are preferred antibiotics for the treatment of pyelonephritis and complicated UTIs caused by CRE? Again, we'll go ahead with ciprofloxacin, levofloxacin, or trimethoprim, or extended infusion meropenem if it is susceptible.
Yes.
For uncomplicated one, we can use meropenem at normal doses, normal infusion patterns, And with competitive UTIs, we have to go ahead with extended infusion. What are the preferred antibiotics for the treatment of infections outside of the urinary tract caused by CRE resistant to both ertapenem and meropenem? In that case, we have to go ahead with combinations of ceftazidime, avibactam, or meropenem, vaborbactam, or imicelacin, relibactam combinations. These two I discussed because this is very common resistance patterns we all get in our ICUs. ESBL send carbapenem resistance. Carba test we usually send to get the gene studies done. Normal gene resistance which we most likely get are NDM strains, oxacillinases strains, or KPC strains. Antibiotic treatments remain same except in NDM strain and other strains other than KPC and oxa, we have to add aztreonam also because those they don't hydrolyze aztreonam. So aztreonam should be added whenever we get any NDM strain in carbapenem CRE pattern. And in KPC, we can add Vero, vaborbactam, or this combination of ceftazidime, avibactam, or any other combination. But in case of oxacillinases like OXA48-like activity, only ceftazidime, avibactam combination works. So I'll conclude now. There are few take points. There is always more to evaluate just an S report in the culture. Not just sensitivity works in prescribing antibiotics. Use of beta-lactam if at all it is possible. Never use the smallest number just because it is the smallest number. As you already said, MIC, low MIC doesn't signify anything. Know the exceptions and ask for help if unsure. Thank you.
I would like to ask one question if one of you would like. I get a CRE and it is an NDL. And so can I administer just aztreonam? Why not? Why not? I cannot administer just aztreonam, you're right, but why not? If it's NDM, then my aztreonam is covering it. It's not getting hydrolyzed. So why can I not just administer aztreonam? Anyone would like to answer this? You can attempt. That's okay. We all are here to learn. Any weird thought that's coming to mind? Synergy. It's because CREs, they don't only produce NDMs. Every carbapenem resistant Enterobacteriaceae will produce KPCs as well. It will produce oxas as well. Just that it's producing NDMs in addition to it. Right? So you have to cover these KPCs and oxas by ceftazidime, avibactam, and NDMs by aztreonam.
That's why most of the time when we don't get the final definitive gene sensitivity report, we add both.